Good afternoon and welcome. My name is Mike Rakowski. I'm the Director of Alumni Engagement for New Brunswick Academic Units at the Rutgers University Alumni Association. This discussion, funded by the Blanche Groswold Memorial Lecture, welcomes speakers each year who, like Blanche, are trailblazers in the field of their work to improve the human condition. This endowed fund was established by James Cone, friends, family, and colleagues of the Blanche Groswold to celebrate and continue her legacy. Blanche Groswold was a graduate of UC Berkeley and worked as a social worker at the Golden Gate Regional Center in San Francisco, California. Her research interests overlapped several fields, including social welfare, sociology, public health, law, labor, and health policy. She also worked as an assistant professor at Rutgers School of Social Work from 2001 to 2003. Blanche was beloved by her husband, friends, family, students, and colleagues at Rutgers for her courage and support of vulnerable populations throughout her lifetime struggle with depression. Today, we are honored to have with us Dr. Emmy Tiderington. She is an assistant professor at the School of Social Work, where she is associate faculty for the Institute of Health, Healthcare Policy, and Aging Research at Rutgers. Prior to this appointment, she served as a clinical supervisor and social worker in housing and case management programs for individuals with serious mental illness and other complex needs. Dr. Tiderington's research focuses on the implementation and effectiveness of permanent support housing, housing first and move on initiative service models, best practices for facilitating transitions out of homeless services, and mental health and substance abuse recovery in homeless populations. She is currently a co-investigator on Dr. Joel Cantor's NIH-funded study examining the contribution of homelessness to race, ethnic healthcare disparities and the effectiveness of supportive housing in reducing those disparities. At Rutgers, she proudly serves on the School of Social Work's Inclusion, Intersectionality, Diversity, Equity, and Advancement Committee, and on the Rutgers University Chancellor's Task Force on Student Essential Needs. Please note, all attendees have been placed on mute for the duration of this discussion. If you have questions, please send them via the Q&A option at the bottom of your screen. We will get to as many questions as we can. It's now my privilege to turn this event over to Dr. Tiderington.
Hi, everyone. Thank you, Mike, for that kind introduction, and to the Rutgers University Alumni Association for hosting this panel. I also want to extend a very special thank you to the family of Blanche Groswold for sponsoring this event. From what I have been told from others, Blanche was an interdisciplinary trailblazer, a strong advocate for marginalized individuals, and just an incredible person. So it's an honor today to be speaking with you as part of a panel that we're delivering in her memory. And I truly hope that it sparks some thoughtful discussion and inspires all of you to intervene in your own way around these critical issues. So the topic of today's presentation, as you may have noticed, is advancing racial justice and health equity through housing and homeless services. And we chose this topic because it's increasingly clear that structural racism and decades of racist housing policies have resulted in serious consequences for the health and well-being of individuals and communities of color, including in our own backyard of New Jersey. So we are lucky enough to be joined by two leaders in the worlds of housing and health who are going to help us talk through these challenges and think about ways to intervene to advance racial justice and health equity in this space. Our first speaker, Dr. Joel Cantor, is a distinguished professor of public policy and the founding director of the Center for State Health Policy here at Rutgers. He's published widely on health services, policy, and innovations in health service delivery, and he'll be speaking with us today about the impact of homelessness on health and how research might be able to get us closer to understanding and resolving healthcare disparities in homeless populations. Taiisa Kelly, our speaker following Joel, is the CEO of Monarch Housing Associates in New Jersey. Monarch is a nonprofit organization that's working to expand the supply, accessibility, and variety of affordable permanent supportive housing through development, planning, advocacy, and partnerships. Prior to this, She received her BA in psychology and anthropology from Rutgers, so is a fellow alum. And she's worked closely with local governments, other nonprofit agencies, and community stakeholders to facilitate the development and implementation of strategies to end homelessness, expand housing opportunities, and create innovative programs targeting those most in need. She has incredible knowledge of housing policy and practices, especially within the state of New Jersey. So we're very lucky to have her here to speak with us today. So to begin, Joel's going to take about 10 minutes to set the stage for us around what is and is not known about the intersection between homelessness, healthcare, and race. Hi, Joel. And then Taiisa is going to narrow the scope of the discussion to what's happening in New Jersey in this regard. And then I'm going to pose a few questions to both of them just to get the conversation started. And we'll open it up for Q&A using that Q&A feature in Zoom. So please feel free to post your questions there and we will try to get to as many as we can. So very excited to be here and to hear from Joel. Joel, go for it. Take it away.
Thank you, Michael and Emmy. And I'm really pleased to have been invited to join you today and add my thanks to Blanche Grosswald's family and the Alumni Association for sponsoring the event. So I'll just walk through just a little bit of background on the issue that we're confronting here. I will talk a little bit at the very end about our new project, and I just wanted to mention that both Emmy and Taiisa are integrally involved in that work. So if you have questions about our future plans, any of us can take those. But just for starters, some basic background information. So what do we know about homelessness and healthcare? So every year, the Department of Housing and Urban Development sponsors a count that's carried out across the country. Monarch Housing leads that in New Jersey, and it happens in every county across the country. And that reveals that there's about 1.4 million people who use shelters in the U.S. On the day of that point in time count, there were almost 600,000 people found to be homeless at the beginning of last year before the pandemic, including about 120,000 people nationwide who were, quote, chronically homeless. And I'll define what that means. It's a HUD distinction that is really important for understanding eligibility for services. The health impact of homelessness is profound. Age-adjusted death rates for people who experiencing homelessness are about 3 or 4 times greater than the average in the population. People experiencing homelessness are at greatly elevated risk of mental illness, substance use disorders, infectious disease, trauma, and a long list of other health conditions. Here's some data from one of our earlier studies illustrating the burden of disease in the chronically homeless population, and this is in New Jersey. So as I mentioned, chronically homeless is a designation that HUD gives, and it's complicated, but as a rule of thumb, people have to have a disabling condition that interferes with their ability to stay housed. And they typically have to have spent 12 months or more in a shelter or on the street over a 3-year period. So this is the tip of the spear, so to speak, of the homelessness problem. And these are extremely high need folks, as you can see here. We found that among those who are chronically homeless and enrolled in the state Medicaid program, 90% had a behavioral health disorder, meaning either a mental health issue or a substance use disorder, or in most cases, both, as you can see on the left side of this slide. Chronic physical conditions are also extremely common in this group, with about 2/3 having at least one such condition. These are things like diabetes, asthma, heart disease, and so on. So there are also tremendous racial disparities for historical and other reasons in the likelihood of experiencing homelessness. African Americans are about threefold more likely to be represented in the homeless population compared to the overall US population. Hispanic, Latino populations also have elevated risk. The services people get are really quite limited. A National Academy of Medicine report not long ago concluded that that homeless persons face overwhelming barriers and obstacles to high quality, continuous, and coordinated healthcare. And that statement has really motivated our work and our thinking about how we can start to reverse that conclusion. Just a little bit more on the background here. So since the early 1990s, pioneering advocates and researchers have been involved in establishing a permanent supportive housing movement to give people, particularly those who are chronically homeless or at risk of being chronically homeless, housing. And there were randomized trials and other studies in the 90s that showed that PSH, permanent supportive housing, certainly improves people's ability to stay in housing for longer periods of time, but it also reduces expensive hospital care, potentially avoidable use of the emergency room and hospital inpatient resources. The characteristics of supportive housing, permanent supportive housing, is that it's not time limited. That's the permanent part. So it includes a housing voucher. And it also is wrapped in a set of services that are voluntary for the participant. So nothing is mandatory here. It includes things like case management, referrals to health and mental health and social services, drug treatment, housing transition supports, landlord dispute resolution, and other kinds of services that are designed to help people maintain their housing over time and recover from their period of homelessness. Just one last point here that I think is relevant for many reasons, and that is that the Affordable Care Act made about 3/4 of people who are or could be considered chronically homeless eligible for the Medicaid program. Prior to the ACA, many of these people were just left out of the system. And the expansion brought them in. Now that's certainly true in New Jersey. There's still about a dozen states, mostly in the South, that have not expanded. But if in most states now, most of the chronically homeless population is eligible for Medicaid. I mentioned that there were some good studies of supportive housing. This is from one of our earlier studies, looking at people who in New Jersey who got supportive housing placements in a 2-year period. The numbers here are the quarter since placement or the quarter before placement. And these show the rates of emergency department spending in the Medicaid program in each quarter. And as you can see, the red line, those who got were fortunate enough to get the placements, their ED use really stabilized upon placement. And it just for the matched comparison group, people who could have gotten placements but didn't, their emergency department use and spending just continued. So this is really a motivating factor for states because these are resources spent on suboptimal care. Coming back to the emergency department over and over means that folks are not getting what they need in the community to prevent acute exacerbations of their serious health conditions. This shows where the changes in spending were in these two cohorts. We saw savings in emergency department spending in hospital inpatient spending, but more spending on prescription drugs than and really no net change in Medicaid spending. So the added spending on prescriptions was really a redirection of resources from the hospital sector. And we think this is a good thing, because very likely these are chronic disease management drugs and people are staying on them, and it is ultimately making them healthier. So that's a quick overview of just a little bit of our New Jersey data and a little bit of the background on the problem that we're confronting here. Taiisa will give you lots more detail about the New Jersey context, but before we go there, I just wanted to outline some things that we don't really know at this point. The research doesn't help us understand, and that sort of frames the new study that we're just presently launching. So we know a fair amount about hospital use among people who experience homelessness and those who get supportive housing, but we don't know a lot about access to other essential health services. I showed the prescription drug number. There's some research on substance use treatment, but things like preventive care, dental services. People experiencing homelessness have tremendous oral health problems. Do they have access to dental care? Community mental health services, are those continuous over time? Do they have a usual place that they can go? A lot is not known about these things. But if we're going to improve services for people, we need to know more about where these gaps are. We also don't know how equitable access to supportive housing is. There's some evidence that supportive housing programs have enrolled folks who may be a little bit easier to manage. And HUD has changed policy to try to change that so that those with the highest needs get the placements, but we don't really know a lot about that, and we don't know the implications of that selection for this really quite limited resource, what the implications are for racial equity. And so that's another important set of questions. So really, how much does supportive housing placement contribute or help ameliorate racial and ethnic disparities in access to services? Most of the research in this area just looks at the first year or two after a supportive housing placement. You know, after experiencing a lifetime of trauma, a tremendous amount of time on the street with uncontrolled health conditions, it may take more than 18 months or 2 years to really see a turnaround in one's health. So longer term studies are needed. And also there's tremendous variation in how these programs are implemented across the country and across counties. And there has been very little work on understanding best practices, what organizational practices lead to the best outcomes, and so forth. And with Medicaid taking so much more responsibility for the care of these populations, there are big questions about how Medicaid policy can be improved to lead to better support and better care for the population we're talking about today. So just a slide or two on our new project, and then I will turn it over to Taiisa. So as Michael mentioned, it's supported by the NIH. We're just getting started. It's a 5-year project, or almost that. Here's the research questions. What's the contribution of homelessness to gaps and disparities in access to a broad array of health services for Medicaid beneficiaries, not just the hospital side, but the full array or a nearly full array of community-based services? Does supportive housing improve access and reduce disparities in these measures, and which measures get better, which don't, where's more work needed? And then lastly, what strategies can be used to maximize the effectiveness of supportive housing in reducing the healthcare gaps and disparities that we know are there? It's a 2-state study. We're pleased to be working with colleagues at the University of Pittsburgh. So we'll be able to look at rural health issues as well because they're joining us. We're using, it's a long-term study. We have about 10 years of data, linking homeless services information to Medicaid claims for the analysis. And it will be enriched with in-depth focus group discussions that folks like Emmy on our team will be leading with frontline workers in support of housing programs to help us understand what the data mean. The data can tell you a lot about what's going on, but not why. And the focus groups will help inform the why, and then beyond the why, what can be done to improve things. And again, we're covering a very broad spectrum of service use in the study, and there's the list on the screen now. So here's our team. In addition to Taiisa, Emmy, and myself, we have other folks from Rutgers, folks from the University of Pittsburgh, and an organization, national organization called Academy Health, which will help us get the word out to federal officials and others. At the bottom of the slide here are some resources if you're interested in volunteering or understanding more about the problem. And these slides will be sent out after the presentation today. And I wouldn't be a good academic if I didn't have a bibliography, so we have that too, and that'll be available to you after the presentation today. So I will stop there and see if I can figure out how to, let's see, stop sharing and hand it over to Taiisa.
Thank you, Joel. Let me just pull up my slides. So it's a pleasure to be here with you all. Thank you, Emmy and Joel, for I'm really honored to be part of this conversation with you, with both of you, and to be chatting with all of you who are interested in this topic about what's going on in New Jersey. As Emmy mentioned, my name is Taiisa Kelly. I'm CEO of Monarch Housing Associates, and a little bit of background about Monarch for those that are not familiar with us is that we are a nonprofit organization that was founded in 1990. So we're about 30 years old, 31 years old. And we are really working towards a vision where every person has access to the quality, permanent, affordable, stable housing that they need that fosters the level of independence that they desire in the community. And we are doing this through our mission of expanding the supply and accessibility of housing through development planning, advocacy, and partnerships. There are two primary teams that we use to carry out this work. First, we have our housing production team, which really focuses on partnering with nonprofits and for-profit developers to create supportive housing, affordable housing, and just really working to increase the supply of housing across the state. And in our 30 years, we've been fortunate enough to help support the work of creating about 3,000 units throughout New Jersey. We also have a homeless planning team that works with communities across the state on developing and implementing strategic plans to end homelessness. We currently work with every county in some form or fashion, but do some intensive work and support for about 19 of the 21 counties in helping to develop strategic plans to end homelessness. Kind of underlying all of this work that we do as an agency is a general core value and belief that housing is a right. We as human beings have the right to access housing. And so we must do everything in our power to ensure that everybody has the ability to get into housing that fits their needs. And the work that we do, we see as a way of kind of setting the stage for establishing a society where housing is a right. Now, in terms of the work we do around homeless planning, we really ensure that we are pulling information from different data sets to inform the strategic plans that are being developed. There are two primary data sets that we use to actually understand what's going on and the trends and the needs of people experiencing homelessness in the state of New Jersey. The first is a point in time count, which Joel mentioned. We at Monarch have been coordinating this since 2014. It's a statewide count, a one-day count of people experiencing homelessness, where we identify everybody who's in emergency shelters, transitional housing, and hotel placements, as well as people who are living on the street, and just survey and understand what their needs are and how long they've been experiencing homelessness. The other data source that we have in New Jersey is the Homeless Management Information System, or as we like to call it in New Jersey, the HIMIS system, which is a database where all agencies who are providing shelter, transitional housing, permanent supportive housing, as well as outreach services and other supports are entering information about each client that they serve on a regular basis, on a daily basis. So this is a really comprehensive database that we have for the whole state, which really tells us what's going on in terms of who's experiencing homelessness and what their needs are. From the point in time count that we've conducted over the last 5 years, and this count occurs in every county through the partnership with local providers in each community, we have seen somewhat of a steady increase in the number of people who are experiencing homelessness in the state. And that increase has been driven by an increase in the number of people who are accessing emergency shelters and those who are experiencing unsheltered homelessness in the state of New Jersey. For this, as you'll notice, the numbers here reflect 2016 to 2020. We did do a count in 2021. However, because of COVID, the methodology, there are lots of different changes with the count. So 2021 is a really unique year. We'll have to see in the future how that pans out moving forward. But we've started to see kind of an increase in the number of people who are experiencing homelessness over a 5-year period. From the HMIS system, there's lots of opportunities to pull many different types of data. This is an example of a type of report that we have been putting together for our communities and for state partners to help inform the planning that they're doing around creating strategies to end homelessness. So this is a 1-month snapshot of who's experiencing homelessness in the state. Looking at the HMIS system, there were about 5,700 people who were experiencing homelessness within that month who were accessing emergency shelters, transitional housing programs, safe havens, and outreach programs. So this is a really comprehensive data set that can let us know who's experiencing homelessness and provide some details about the different characteristics of those who are experiencing homelessness. At Monarch, we've been doing some work on digging into this data a little bit more. And one of the things that we've really been focused in on is really digging into the racial disproportionalities within the data and understanding what the data is saying around that. From the point in time count, we have been looking at the disparities, racial disparities for about the last 5 years. So about since 2018, the annual point in time count report that we produce has included a section where we look at the disparities in who's experiencing homelessness. What you see here is information from the 2021 point in time count. And I will tell you that this is pretty much the same information we have been seeing for the last 5 years since we started doing this work. Those who are experiencing homelessness, there's a significant disproportionality in who actually experiences homelessness in the state of New Jersey. So for example, white people in the state represent about 54% of the state population. Just to note that reflects 2019 census data. And they reflect about 24% of the population experiencing homelessness in the state. Conversely, Black people represent about 13% of the state population, but represent about 50% of the population experiencing homelessness in the state. So this is a consistent trend that we've seen over the years. Now, often poverty is identified as a driver of homelessness and a driver of who will experience homelessness. If that were the case, we would expect to see that the numbers of people experiencing homelessness by race would mirror the numbers of people who are experiencing poverty by race within each category. But as you can see from this chart, neither the general population nor poverty really indicates who's going to experience homelessness. And what we consistently see is that race is a more significant factor in terms of understanding who's going to experience homelessness than poverty itself. From the HMIS system, this data actually reflects information from the month of August from that first report that I showed on the previous slide. This is just looking at who's actually experiencing homelessness in the system and breaking down the specific subpopulations amongst those who are experiencing homelessness. So similar to what we found on the point in time data, within the HMIS system for the month of August, white people represented about 20% of the population experiencing homelessness, while Black people represented about 55%, and people identifying as Hispanic Latino represent about 18% of the population. With that understanding of what the breakdown is of the general population, we also see that there are significant differences in the subpopulations that are experiencing homelessness. So for example, white people seem to be overrepresented in the chronically homeless population as compared to their rate of homelessness within the total population. Conversely, Black people seem to be overrepresented in the population of people who are experiencing long-term homelessness, as well as in the population of homeless families. So these distinctions are really critical in understanding how we design programs and supports to address the needs of people who are experiencing homelessness. And so, communities are digging into this data on a regular basis to understand, do they have the right programs? Do they have the right policies in place to impact the needs of those who are experiencing homelessness in their community? One of the things I wanted to kind of point out to highlight this a little bit more is that through the point in time count, one of the questions that we ask is, do you have a disabling condition? And this is a self-reported piece. So looking at the numbers from the most recent point in time count in 2020, we found that about 68% of white people experiencing homelessness reported a disabling condition and said, yes, in fact, I do have a disability. This is in stark contrast to other communities of color, where less than 50% of the population identified as experiencing homelessness positively informed the interviewer that they had a disabling condition. Now, this in of itself is a pretty interesting piece, but we also want to look at this in the context. As Joel mentioned, over the last probably 15 to 20 years, there has been kind of a movement at a federal level to really ensure that resources are geared towards those who are most vulnerable within our system, understanding that those who are most vulnerable will use the most resources within our system, as we've seen from the hospital data. The challenge that we have is that if vulnerability is defined by the presence of a disability, and white people experiencing homelessness are more likely to really identify that they have a disabling condition, that will help to perpetuate the disproportionality and the disparities that we're seeing in who's actually experiencing homelessness and who stays homeless in our communities. So this data presents some really interesting questions around how we develop policies and whether or not our policies are geared towards addressing disparities or perpetuating them. As Joel mentioned, the data just tells us what's going on. It doesn't tell us why. So there's lots of reasons why the data could look this way, white people being more likely to report disability versus people of color. This could be a reflection of the interaction of different communities with the conversation of disability and whether or not they are comfortable admitting a disabling condition, and may not necessarily reflect the true prevalence of disability or vulnerability within that community. Or this could be a reflection of the fact that for white people experiencing homelessness, they tend to be higher risk, more vulnerable, because a white person in the same position as a person of color in one of the other areas would probably not be experiencing homelessness because there are a lot more supports around to help prevent them from falling into the system. So we don't really know why the data is looking like this, but it does definitely point to a place for further investigation, and also has some significant implications in terms of the policies that we develop and the impact of those policies. Now, the conversation about equity and homelessness is a relatively new conversation for us. I know in the health sector, this has been a conversation that has been going on for quite a long time. But for the homeless service sector, this kind of dealing with the question of equity and disproportionality with in terms of who's experiencing homelessness has really only been something that's been happening over the last 5 years. And so at a national level, there have been conversations about who's at the table, who is helping to create policies? Are we collecting the right types of data to really inform the policies that we're developing? And how much value are we placing on the experience of people who've been impacted by homelessness? How much do we invite them to the table to participate in creating policies and developing regulations? And what we've seen over the years that there's been an increasing focus on this conversation. And at the federal level, we've seen the Department of Housing and Urban Development create new requirements around programs to ensure that communities are starting to look at their data more closely and are starting to invite more people around the table and really be intentional about including people with lived experience of homelessness in the policy setting of the community. In New Jersey, this has looked a little bit different, has happened in a variety of different ways. But I'm happy to say that this conversation is taking hold in New Jersey. So in 2019, Monarch was fortunate enough to help coordinate a summit on racial equity for the state. And we brought together lots of partners from local planners, state partners, as well as providers and people experiencing homelessness to begin to talk about systemic racism, housing, discrimination, the impact of the history of racism in our state, in our society, and how that impacts the homeless system and the numbers that we see today. Communities across the state have started to do a little bit more data analysis and digging into the outcomes in their data to understand if there are disproportionalities happening in terms of the successful outcomes in terms of connecting people to permanent housing, as well as understanding if there's disproportionate rates of who's experiencing homelessness by subpopulations. At Monarch, we have been really committed to continuing this conversation and really ensuring that the work that we're doing around developing strategic plans to end homelessness include this equity framework. So we were fortunate enough to secure a grant through the Robert Wood Johnson Foundation around building healthy communities. And as part of that, we have been working with about 9 counties throughout the state and the State Office of Homelessness Prevention under the Department of Community Affairs to really help facilitate conversations around systemic racism, housing, and homelessness. And as part of that, we've also been working with communities to help develop advisory boards and host focus groups with people who've been directly impacted by homelessness to understand from their perspective what is working in the system, what's not working in the system, and have a better understanding of the impact of the policies and the regulations that are put into place. So there's a lot of work happening. It's at the very beginning stages, but there's definitely a lot of movement in this direction. One of the things that I want to just highlight as to why this is so critical to have this conversation now and to begin this work is that there's an opportunity here to end homelessness. Now, I know when I say we can end homelessness, a lot of people do actually, in my mind, I believe that they're rolling their eyes about that concept because homelessness has been so ingrained in our society and has been such a fixture that oftentimes it's hard to believe that it's possible. But I want to tell you that it actually really is possible. So this is the second part of the analysis that I showed you in the first slide or the second slide that we've put together at Monarch that looks at who's experiencing homelessness in the state, breaking down that group into different subpopulations. And we estimate that if we were able to provide $150 million, if $150 million were allocated to communities, to programs, to provide rental assistance and support services, that we could actually house those 5,700 people experiencing homelessness in New Jersey. This was during the month of August, but at that particular moment in time. So there truly is an ability. For some of you, 150 million sounds like a lot, for others probably doesn't, but to put it in context, the state of New Jersey over the last year and a half received $1.6 billion from the CARES Act and from the American Rescue Plan, specifically for programs that can address housing needs and service needs of people experiencing homelessness or just general housing and service needs in the community. Now, not all of that $1.6 billion is specifically dedicated to people experiencing homelessness. There were lots of other competing interests and priorities such as PPE, testing, all those other pieces where that funding could be used. But if we were to look at just the money that was allocated specifically for the homeless service system, there was about $330 million that was allocated in the state of New Jersey, new money that came in through the CARES Act and American Rescue Plan. So the $150 million that we need to end homelessness represents less than half of what came into the community as new funding. So when we talk about the conversation of can we end homelessness, what will it take to end homelessness, and why is it important to end homelessness? If we are really interested in addressing equity, if we are really interested in restructuring our systems, investing in ending homelessness is, and housing people is, a solution to the inequities that we're seeing in our system. So we can do it, we just have to divert our attentions and invest in the things that we know will work to actually make that happen. Thank you, and I'm happy to see where this conversation goes and answer a couple of questions.
Hi, everyone. Thanks, Taiisa. That was fantastic. And Joel, I really appreciate both of you taking the time to chat with us about this and set up the issue here. I think I want to, so I see some Q&A questions and we'll get to all of those. And people feel free to put more in there and we will try to get to all of them in the 15 or so minutes we have. So I just want to take a step back, and this is a question for either Taiisa or Joel, whoever wants to take it, but you both presented in some ways hopeful, but also in some ways a bleak picture with regards to racial and ethnic disparities in housing and healthcare, both here in New Jersey and across the nation. I think the statistic that has been presented quite a bit lately about African Americans being 3 times more likely to be homeless than the general population always hits me like a ton of bricks. So I wonder if either of you could speak to how we got here. What were some of the policies or practices that may have caused these disparities? their unintended or intended consequences, and to learn from our past mistakes, it's essential that we articulate and acknowledge these issues. So I think it would be great if either of you could offer us your thoughts on contributing factors and what led to this.
Taiisa, you want to start?
Sure, I can take a first stab at that. So I think that we can't ignore the history of redlining, the history of just, systemic work to keep Black people out of society. So, I mean, really from the founding of this country, Black people were not necessarily equipped to become full members of society. They, with slavery and then the abolition of slavery, there was never an intentional, or there was not a long-term, I should say, intentional effort to really address that and redress that. So we have a group of people, Black people in this country, who have never had the opportunity to fully engage and to access all of the opportunities that this country has been afforded. And if you kind of fast forward a little bit further to kind of the more recent history, there has been a long history of really locking Black people out of housing opportunities within this country. Redlining is probably one of the more well-known, and for those that are not familiar with it, there were systemic efforts by realtors, by housing planners, and at the federal level by the federal government to identify which communities would be appropriate for loans, for federally backed loans. And typically those communities that were identified as communities where Black people lived were redlined, were identified as poor communities that loans would not be approved in, and communities where majority or only white people lived were the communities where loans would be approved. So there was a systemic effort to really lock Black people into communities that were not able to access home loans, home ownership. You couple that with realtors steering Black people to Black communities and keeping them out of white communities. We've had histories of developments really having racial covenants where they said houses could not be sold to Black families. You have the building of Levitt towns actually in this area in New Jersey and in New York, where whole communities were built specifically for and only for white households. So I think if you add all of that together, you lock Black people out of opportunity into communities where there are less opportunities, there's poor educational opportunities, there are limited access to jobs, all of these factors. And then one day we say that these things are no longer allowable, but we haven't done anything to redress that. This is where we start to see the disproportionality in who's actually experiencing homelessness, because at the end of the day, Black people in this country are still primarily locked into communities that are have less resources, have less access than white families in America.
I'll just add, if I may, that clearly that set of factors, Taiisa, are root causes of these disparities that we're seeing and the underlying problems. I will add to that the way we have managed mental health policy and substance use policy in this country over many years, from a time when essentially anyone with mental health problems was at risk of being essentially locked away in an institution. And then we moved away from that as a society, but never stood up the community mental health resources needed to take care of them. Substance use policy, likewise, has been racially biased from the beginning, with use of crack cocaine, landing people in jail for very long terms and being arrested with powdered cocaine, the sort of white middle class version, much less so. We haven't talked about this much, but as you saw, that there's cycling from the street to the shelter to the emergency room to the hospital, but the other big piece of that is the criminal justice system. And anyone paying attention to the news in the last year just saw how the criminal justice system has not remedied these problems, I'll put it that way.
Yeah, thanks for both of those responses. Taiisa, you mentioned that COVID has led to some kind of influx of resources to address some of these issues. Do you think that there are ways to use those resources or other resources to address some of these root causes around that you mentioned around landlord discrimination, Black home ownership, and kind of putting money in those buckets? Is there anything that you know of that's being done in those areas?
So I know that there's lots of conversation around this, and I'm sure there are many programs across the country that are looking to try to jumpstart this work. One thing I will just kind of, I guess, put out there is the idea that a lot of this, at this point, a lot of the issues that we're seeing and a lot of the issues that we're confronting are in the details. And so there are many well-intentioned programs that don't go deep enough into the details to determine whether or not they're going to have the positive impact that they're intending to have. And so in order for us to really get to this place of having the resources that have been available through the CARES Act or the American Rescue Plan have the significant impact that we're hoping for, we really have to start to look at the details of how these programs are being implemented and ensure that that is occurring with an equitable framework. And the first step of making sure that those resources are put out in an equitable way is ensuring that those who are around the table planning for those resources look like the communities that they're intending to serve. And unfortunately, I can't say that that happens very often in any planning space or many planning spaces.
Absolutely. I think that that's a good segue into thinking about effectiveness and impact and really understanding systematically whether the programs that we put together are actually working in the way that they're intended and how research can inform that work. So I think, Joel, there's a couple questions in the chat about just kind of logistical questions about why Middlesex and Bergen were excluded from the study. So it would be great if you could speak to that. But then also, I kind of want to throw out a crystal ball question for you and just think about, what do you think we're going to find from this giant, what is it, 5-year study that we've got, a massive study based on what we know from previous research in this area? Do you think that we will find that permanent supportive housing is an effective strategy at a population level for addressing healthcare disparities in homeless populations? How do you see this going? I'm curious, what do you think will happen? And also this, why not Middlesex and Bergen?
Right. So first of all, let me say we would love to include Middlesex and Bergen, and the reason that they're not in yet just has to do with the way data are managed and who controls it and how many lawyers are involved. And New Jersey has a nearly statewide system for its homeless management information system, but 2 counties run their own platforms. So as soon as we get the ink on the data use agreements from all the lawyers for the statewide, we will be reaching out to those 2 counties to see if they're interested in participating, and we'd love to have them. The crystal ball is a harder question. So I think we're going to find that connections to those essential community services that people need are weak and inconsistent. But I'm also hopeful that we find that in some places they're much better. And that we can learn lessons from those positive experiences. Maybe a county level program or an individual supportive housing program in a locality just may be able to be connecting people to those positive resources more readily, and that we can really draw lessons from that. This is a like so much in public administration. Homeless services and healthcare services have traditionally been in their own silos with lots of complexity of working across those silos, data complexity and legal complexity and just time and bandwidth. Now that there's so many more folks in the Medicaid system who have been experiencing homelessness, I think we have highly motivated audiences to make life better for these folks, that it has really expanded responsibility for fixing the problem. And I think that there is an eagerness to do so. And I'm hoping that the data we generate will point to where those improvements can most readily be made.
Absolutely. And I do think we're now kind of in the field hearing more and more housing is healthcare, right? And a recognition by these systems that one results in the other. And so when healthcare programs and supports like Medicaid can put money towards those supports that keep people housed, it can really pay off for them as well. I just wanted to acknowledge the question in the chat that said, do you know if Rutgers University or New Brunswick have health clinics available for the homeless population? I do know Elijah's Promise provides their clients for their soup kitchen, as well as the greater New Brunswick community with primary care, health screenings and tests. And they work with medical students from Rutgers Medical School. I don't know if you guys are aware of any other resources, but I know we have that.
I'll just mention the Chandler Health Center, which is part of Rutgers as well, located on George Street. It's a general services, primary care and other services for low-income people, regardless of ability to pay. And of course, people experiencing homelessness are welcome there as well. Promise Clinic really is focused on, because it's connected to the shelter, it is really focused on helping this population in New Brunswick. I'm sure there's lots of good examples in Newark and elsewhere as well. I just don't know those offhand.
Yeah, I will say, like, across the state, there are efforts to be more intentional about connecting healthcare to people experiencing homelessness. In Camden County, New Jersey, there is the Camden Coalition for Healthcare Providers, where they have a really intensive program that they've developed where a person who's experiencing homelessness, if they show up in one of the hospitals in the community, the hospital immediately alerts the outreach team so that they can engage the person with, and this is all kind of done from an attempt to decrease the number of times people are bouncing around from hospital to hospital before they're getting supports. Unfortunately, there's not an even, integration of those types of supports across the state. So it really depends on the resources available in each community and how much they can coordinate that. But there are efforts happening, and I think there's always room for more coordination between healthcare and homeless services in communities.
Yeah, absolutely. I would agree. I like this question that someone posed in the chat that, and I think we all grapple with this question a lot. So the question is, it seems like we have the means to end homelessness, but haven't actually invested in doing so. And another person says, when do you all think we'll move from research to action? So we, and we're all guilty of this. We do a ton of research in this area. We have a lot of foundational knowledge about what ends homelessness. And this is not rocket science, right? We know housing ends homelessness, but we keep doing research. We keep putting these solutions out there, and we have not ended homelessness. So I'm curious what you both think about this criticism of, or just general question about why we have not gotten to that point.
I guess I would just offer that I think that there are still a lot of foundational pieces that we haven't really all agreed on in this work. There's an assumption that everybody's at the table to end homelessness. And the hope is that everybody's at the table to really end homelessness. But if your focus is on getting people connected to health support, or stopping substance use, or making sure people are participating in treatment, housing is a secondary piece. And that can have a tremendous impact on where you focus your efforts and what solutions you come up with, or where you invest in solutions. The other piece I will say is that we really cannot ignore that this conversation of race and how it intersects with homelessness really is at play. And if we do not address this conversation of what the system is really intended to do and what we're prepared to do as a society, then we will always be kind of fumbling back and forth between research and action. Communities have the potential financial capability to end homelessness, and the responses that come up as to why we're not ready to move in that direction really can be telling about where the community is in terms of whether or not they have truly believed that people deserve housing, and whether there's truly an understanding that housing is a right.
Absolutely.
Yeah, and I would just add that, well, I don't think research is going to solve the problem here. It can contribute. I think this area is one example where I think research has already made a huge difference. It's not our work, it's the people who came before us. There was a tradition in the 80s and going into the 90s of sort of forcing people who were experiencing homelessness and say substance use to quote, take responsibility, get treatment, and prove that you can do better, and then we'll give you transitional housing. And if you then get your mental health treatment, we'll move you up the ladder. But some innovators in the field working with researchers documented that giving people housing unconditionally in the movement called Housing First, as the name implies, unconditional housing actually helps people quicker and more sustainably. And that came from randomized experiments and the kind of work we're talking about here. And I think it changed the conversation. It changed HUD policy. And of course, we don't know what insights we'll generate from our research yet, but I would consider myself lucky if we can inform a debate about addressing these deep inequity questions that we're observing here.
Absolutely. And I would agree with both of you. We are going to jump back to Mike in a second, but I just want to put a call out. Appreciate both of you guys sharing where we're currently at, where we're going, and what else is needed to get that political will towards ending homelessness. We have a lot of opportunities, but again, that political will really needs to be there. So for Rutgers alum or anyone on this call, resources that we want to offer to you all to get involved and for you all to be able to help address racial justice and healthcare disparities for homeless populations. The National Low Income Housing Coalition does great advocacy work. If you're interested in working with them to call, on calls to action to get politicians on board with this and the right policies out there, the right resources out there. National Alliance to End Homelessness is also an excellent advocacy group that really knows what they're talking about. So if anyone's interested in doing more on your own to move the needle on this issue, check those folks out, and we will provide that information as well. Thank you both.
Thank you.
Thank you, Dr. Tiderington, Dr. Cantor, and Taiisa Kelly. Thank you for all of your great questions this afternoon, too. And on behalf of the Rutgers University Alumni Association, we'd like to thank you for sharing your time, your wisdom, your expertise this afternoon. Thank you to our attendees. We hope everyone stays safe during this time, and we hope to see you soon. Have a great afternoon.